Good day. I'm Ronke Desalu from the Lagos University Teaching Hospital, Lagos, Nigeria, and I'll be talking about critical situations in pediatric airway management. I have no conflict of interest. Critical situations in pediatric airway may be anticipated or unanticipated, and they rapidly deteriorate into poor ventilation and oxygenation, hypoxemia, which can lead to bradycardia, and bradycardia can culminate in a cardiac arrest. Airway difficulties in neonates and small infants are of concern. There may be difficulty with visualization of the glottis because of the small mouth, the large tongue, the anterior larynx, and the floppy epiglottis. And they rapidly desaturate due to their reduced functional residual capacity and a high oxygen consumption. In anticipated difficult airway, we must have experienced personnel, and it is a team approach with the anesthetists, the surgeons, and the ENT surgeons. We should have a plan A, a plan B, and a plan C, and also plan for a failure. We should have all the appropriate equipment, one to be able to visualize the larynx, and a reliable option in case we cannot intubate the trachea. We must have adequate monitoring, most especially capnography and pulse oximetry. And we should pre-oxygenate them ideally to increase the oxygen content in their functional residual capacity. The difficulty we encounter may be with maintaining a patent airway, mask ventilation, laryngoscopy, or tracheal intubation, or the dreaded can't intubate, can't oxygenate scenario. There are different pediatric difficult airway algorithms available. Most of them are from age 1 upwards, and mainly for unanticipated difficult airway. The Paediatric registry recommends that attempts at intubation should not exceed 2 to 3. The general principles are to preserve spontaneous ventilation because this helps retain upper airway muscle tone. If we must give a muscle relaxant, we must test ventilate before doing that. We should avoid repeated intubation attempts because this only causes trauma and airway edema. And we should change the approach because the anatomy will not change for us. And this is where we have our plan A, B, and C. So which route should we take? Sometimes it may seem as if we're navigating a minefield of mousetraps, but we shouldn't pull our hair out. We should have a plan. I saw this beautiful diagram by Sawa et al. That shows us different routes that we could take, whether the patient is awake or semi-awake or under local anesthesia, or whether the patient is under general anesthesia. We need to check the connections. This beautiful chart table came from Update in Anesthesia, volume 30, and it shows us what fits into what. And we need to ensure that all our connections fit. Then we decide, are we going LMA, fiber optic endotracheal tube, or are we using a guide wire, or are we going to use a guide wire and an airway exchange catheter? All these should be decided before we put the child to sleep. With some congenital abnormalities, we may need to do some imaging to determine the trachea position. This is important because it tells us where the trachea is and gives us an idea of how to navigate. It also helps the ENT surgeons if they need to do a tracheostomy. For these two cases, a fiber optic is ideal. We would apply vasoconstrictor to the nose, employ local anesthesia spray as you go, with or without sedation, with or without ketamine, ensuring oxygenation through one nostril, with or without a volatile agent. The child on the top, we had prepared everything, but luckily we were able to intubate under direct laryngoscopy at the second attempt. With genetic syndromes, they are difficult to intubate without advanced airway equipment. And we need to decide whether a a supraglottic airway device will suffice for the procedure, or whether we need to do a tracheostomy. The child with Pierre-Robin syndrome on the left was scheduled for surgery 3 times and we couldn't intubate. On the 4th time, we had to do a tracheostomy. The Golden Horse syndrome patient, we couldn't intubate as well, and we are scheduling her for fiber optic intubation in the future. Sometimes it looks worse than it actually is. With this patient, we had made adequate preparation, including ENT standby, but we were able to do a direct laryngoscopy and intubate the patient. With early burns, early intubation is recommended before any edema sets in. We can intubate, we can induce the child inhalationally, we can use ketamine. Succinylmethonium is safe if it is within 24 hours. We should use a smaller size tracheal tube and ensure that the tube is in the correct place. With late burns, there may be restricted mouth opening, restricted neck mobility, and also the problems of using succinylmethonium with late burns. If you have rocuronium and sugar Madex, then you can use that. The route of intubation may be through fiber optic, or you can use ketamine or supraglottic airway device. The surgeons release the mouth contractures and then you intubate. Or you can do a tracheostomy under inhalational or ketamine with local anesthesia infiltration. Just a brief word about rescue techniques, front of neck access. The Advanced Pediatric Life Support and the Difficult Airway Society differ in their age recommendations for surgical cricothyroidotomy and needle cricothyroidotomy. The cricothyroid membrane is small and difficult to locate in small children, and the trachea is elastic and prone to collapse. In children less than 1 year, both societies agree that a tracheostomy may be more appropriate in them as it is easier to locate the tracheal rings. I saw this article in Anesthesia Tutorial of the Week about the difficult airway trolley, comparing the high versus low resource setting. They showed that the difficult airway trolley differed in the numbers available, the site where it was kept, and the content. So I did an online survey of the availability of pediatric advanced airway equipment in Nigeria. 240 anesthetists from 25 hospitals across the country responded. 28% of the hospitals had pediatric McCoy, while only 16% had pediatric video laryngoscope and a pediatric fiber optic bronchoscope. The McCoy was the commonest difficult airway equipment chosen and the one with the highest expertise. 35% of respondents did not have access to expertise for pediatric tracheostomy. This is the pediatric difficult airway trolley in my hospital. Unfortunately, we do not have a fiber optic bronchoscope, but I hope we'll get one soon. In conclusion, poorly managed difficult airway can lead to mortality, and we need to plan the technique preoperatively. Each case is different, and so each case must be planned so that this chosen plan is tailored to that case. We should have an ENT surgeon on standby, check all our equipment and have them nearby, and plan to wake the child if needed. My recommendations are that we should have more hands-on training with the modern airway instruments to develop better skills. This can be done through simulation or in clinical practice. And we should think about the formation of a multidisciplinary airway team. These are my references, and I thank you for your attention.